Cardiopulmonary Sciences master's degree for the 2000 and completed in 2020. And after 2020, if I remember her tributary, Shraddha, Ani, and third one is the Vaidai. So they roam around the campus together in the class. They sit together, and only during the exam they are separated. Otherwise, majority time they are together in the campus. Okay, even during the break time or during the lunch time. Okay. So even though they are notorious, but they are sincere in the study. Okay. So after her completion of master, she was joined as an assistant professor in MGM University, MGM College of Navi, Mumbai, and as an assistant professor. And she started the ICMR project, which is ICMR, that means Indian Council of Medical Research, which is a renowned research body which gives the fund for the specially well projected and well planned the research area, which is newer for the innovation for this physiotherapy. Especially, she started this ICMR project related to the patients with the pulmonary hypertension. So pulmonary hypertension, which is a less touched area in the cardiopulmonary aspect, let me tell you. Majority time we touch the COPD or bronchiectasis or the CABG like that. But the pulmonary hypertension is little less touched area. So she herself involved in the pulmonary hypertension related to that patient. So it is a good task to do that. After that, she also having the good clinical interest and the practicing area in the Mumbai. So she is working in the different hospital setting as a private practitioner, also as a physiotherapist in the different renowned hospital in the Mumbai. And she is treating the many different cardiopulmonary conditions like COPD, ILD, and even after post-operative conditions or the conditions like related to the interstitial lung disease or pulmonary hypertension. And she is also passionate about her teaching methodology, that is case-based learning. So live patient demonstration as we did we're doing in our case presentation, and even by assuming or the kind of PBL, problem-based learning. So she is more about the kind of case-based learning in her teaching methodology. So she is involved as a teacher with the different methodology. So here I can say that she is involved herself in the different aspect. Like clinical, she is treating different patients in different hospitals. Research, like ICMR funded project. Community work, she is treating different kind of conditions. And as a teacher in the teaching with a different methodology. So she is involving in different four aspects as a physiotherapist. So I really have a good to have the Dr. Shraddha here. So I will welcome her to start her speech for this. Thank you.
Thank you, Jitu sir. Good morning, everyone. So I would like to know which batch do we have here? Which year? All the years.
Third year, final.
Third
And first year also.
Okay. Yeah.
And some are from your hometown.
Nice. So today we will be talking about pre-filled, since we have the theme by WCPT, that is healthy aging. For this year, the theme for World Physiotherapy Day is healthy aging, right? So we have the theme. Of healthy aging. So on based of that, we will be talking about what is frailty, what is pre-frailty. Majorly, Arshi Didi has covered all the topics like what is the assessment, what are the markers, how do we assess and how do we diagnose someone with pre-frailty or someone having frailty. I will be majorly touching in cardiorespiratory conditions, right? Now, do we have cardio PGs here? Yes. So, you all must have read, right? So, what all cardio conditions have frailty? What common conditions have you all encountered that have frailty? Sorry? hypertension. Okay, long-standing hypertension can cause hypertensive heart failures and it can present as frailty. So when we talk about frailty, now frailty is sometimes overlaps in the organic condition that the patient has, be it heart failures, be it long-standing hypertension, long-standing diabetes. Okay, it is not very apparent and not visible. Cardiopulmonary conditions, when we talk about patient 60 plus years, if he is having heart failures or any other conditions, you will not know, unlike musculoskeletal or a neurological disease, that the patient is having X amount of disability, right? So it is a non-visible disability that a cardio patient has. So what we have in our way to form is that we can take few outcome measures through education. We can address the patient that these are the three things that we have to observe, and then we can diagnose them with frailty or pre-frailty. Alright, I'll quickly run through. So you all know who is he? So he is Mr. Byron Johnson. Somewhere around 10 months or 1 year before, he claimed to reverse aging. Okay, he claimed with many scientific, very expensive scientific experiments that aging can be reversed. Now you all believe that can aging be reversed? No, right? Aging. Now what do we mean by aging? Like what cannot be reversed? We will age. Today or tomorrow we are going to age. Now what he claimed was that whatever the physical impairments that you are going to get in your senile period, that can be reversed. Okay, so he conducted very expensive experiments like plasma transfusions and all with him and his son to claim that aging can be reversed. Although not very safe to conduct such experiments, eventually what he came out of this experiment is that irrespective of any plasma transfusions done or not, if you follow healthy lifestyle, be it your physical activity, healthy nutrition, and following all the lifestyle based approaches, you can not stop aging, but you can have a functionally able aging. Okay, we must have observed about homes that some are very senile, some are very frail, weak to do anything, even if they want to get down and go to temple, it is difficult for them. But some age really well, right? So it is something what the person has done throughout his life. It is just not in the aging period. So whatever the person has done throughout, how active he was throughout the life, it shows in the elderly period. Alright, so it was a very famous project that had come by him, that was Project Blueprint. You all can go across. Now what is frailty? So, sorry. There is no single gold standard definition of frailty as yet. When you see any systematic reviews, the definition of frailty were taken by various researchers are different. Okay, so whenever you go through them, you understand what they have accepted as frailty and what they have accepted as pre-frailty. Frailty is most often defined as an aging-related syndrome of physiological decline characterized by marked vulnerability to the adverse. So these are our vulnerable group. Now if you see the data of India by 2050, somewhere around you will have 20% of the people who are going to be in the elderly age, 60 plus. So how much it is going to increase the healthcare burden? How much is going to be the utilization of healthcare resources, right? So to prevent the healthcare utilization in the frailty period, what we can do, we can start our lifestyle-based interventions in the pre-frailty period. So to know that who is in the pre-frailty period, we need to do a lot of screening. Because as I said, it is not observable, it is not going to be visible. So for that we need to do some physical assessments, right? So it's a multifactorial syndrome and is associated with malnutrition, inadequate physical activity, sarcopenia, hormonal imbalances, and multimorbidity and varied socioeconomic conditions. A clinical syndrome of decreased physiological reserve and resistance to stressors. It is characterized by weakness, and we already discussed about weight loss and unexplained weight loss, exhaustion, slowed performance. Now, as we talk about many personal experiences, I myself have a personal experience that my dad, he tells me that he has some slowness. Then initially I used to just ignore it, no, it is okay, fine and all. But then now that I have come across this varied terms, so now I realize, okay, maybe he fits into the category of pre-frailty, and it is not something to be ignored. Right? Even they are into denial, as you all said. They are also into a denial. It is fine. It is health. It is just age-related thing. But we never know what it might end up. Alright. So it is important to screen and address it then and there. It predicts disability, hospitalization, and institutionalization and mortality. So it's associated with the prodromal stage, that is pre-frailty, a potential reversible. Now here the keyword is reversible. Anyone in the pre-frail period, we can go back to the healthy or the robust condition if we intervene at that particular stage when we have classified them as in the pre-frail period. The Survey of Health, Aging and Retirement in Europe study found that the prevalence of pre-frailty in 10 European countries range between 34 somewhere around 50%. So how much you understand the burden is somewhere around 50%. Similar or it is greater is the number going to be for India and all the lower middle income countries. Right. So we know what we are going to encounter in the next 10 to 15 years. Right. When you all will be graduate, what are you all going to encounter is all the people with frail and pre-frail conditions. Right. So since it is reversible, we can always start our approaches to prevent. Cardiovascular diseases are the fundamental rights in the prevention of the diseases. Okay, so the preventive approach is to target frailty and to stop frailty in the pre-frail period. So it's a transition between robustness and frailty, defined as 1 or 2. So whatever our outcome measures are for frailty, if the patient scores 1 and 2 in that particular outcome that we have used for frailty, then we can classify them under the umbrella of pre-frailty. Often this reversible is addressed early, and there is always a window for prevention. So we have majorly covered, we have already discussed all these things. Just I would like to mention here that what are the types of pre-frailty. Obviously there is going to be a physical impairment observable when we screen. That also only after we screen, otherwise patient will naturally keep on slowing down activities and naturally cut down his physical activities. So he might not report it because he himself has not observed it. Okay, so for that we need to assess social interactions. Very, very underestimated and ignored thing is about social interactions. Now my dad himself has retired. So what encounter he used to have in day-to-day life, he is missing that. Right? So how important it is to have just a call with a friend. Right? So we should not ignore the social isolation that the patient, or not patient, the person is going to encounter. So even that is important. So that is why community-based rehabilitation or community-based interventions are more important. Where there is a group session done, so any individual can observe some another one, they can have a good chat and they can discuss what they have done throughout their life. Okay, so it is important to address social interactions also. Cognitive system, as already we have discussed about what are the cognitive impairments they might come and how can we address them. Nutritional imbalances can happen because now yesterday itself I was reading an article where they have said that early to diagnose somebody with an early in the pre-frail, there is something called oral pre-frailty, where the patient might show initial signs of difficulty in chewing, lowering of speech, lowering of volume and pitch of the sounds. Okay, so that is the oral pre-frailty. That is the earliest marker it has been observed for anyone to be falling into the pre-frailty. So we can address that with the huge screenings now. As Dr. Hariyara mentioned, you all have been doing a lot of community screenings. I think this can be included in that, and we can categorize someone into pre-frailty or frailty and address those then and there. Why it matters? Now why does हमको क्या मिलेगा? So much happen. What are we going to get? When I talk about specifically cardiovascular conditions, the burden is only going to increase given that the level of physical activity we have, the kind of food we have been consuming. So the cardiovascular diseases are only going to increase exponentially from here. And frailty is going to add on to that, or it is already under that. Okay, so healthcare utilization, it is difficult for the policy makers also, and all the schemes that the government has been providing. It is difficult for them to who will fit into what. So it is also going to create an economic havoc, right, to the government. Associated with increased risk of falls, hospitalization and functional disease. Now when we talk about functional decline, we also have to take into note that along with the person who is frail or who is demanding some form of assistance, there is also a caregiver who is giving a lot of time, lot of effort and lot of resources to take care of that person, right? So it is not just one person, it is two persons who are engaged into the care. So that is why prevent is always the motto, be it frailty or any other cardiovascular condition. What is our evaluation approach? So we have to do a thorough geriatric assessment, functional ADLs and instrumental ADLs. What does the person like to do really? What does he aim out of our rehabilitation? All he must be aiming is that he just wants to go to a farm where he used to go earlier. Okay, he does not want to run a marathon. Okay, so it should be thoroughly what he wants to do in life and not what we want him to do. Okay, all he wanted, maybe he just want to go to a temple in the morning, which is some 1 kilometer away. Okay, so what patient wants, they only want the outcomes. If I tell them that 20 minutes chalo, 70% of maximum, they are not going to understand that. And they are least bothered, whatever it is. Right? So we have been doing a lot of support groups where we try to educate them, where we have realized what do they take our messages. Do they understand that 30 minutes of walking, 20 minutes of moderate or vigorous activity, do they understand that? No. They are only interested in what is the outcome. Will I be able to go back to work? Will I be able to do the painting work that I have been doing all these years? Okay, so you understand what the patient wants and not what we want from the patient to do. So that is about their ADLs. Cognitive screening and depression, again, as Dr. Arshi already explained, so it should be dual task. It can start with simple tasks also, right? It need not be something very huge and something very complex. Nutrition and weight history. Now another complication that the geriatric population face is the problem of polypharmacy. We know that all our elderly, they have some big dabba of medicines, right? They have some 12-15 medicines they have been taking during the day. So that is another challenge we are going to face sooner or later because all the drugs have drug reaction. So polypharmacy is another, it is only going to add up to the frailty, right? So that is why it is important for the physicians to time and again review the medication. So this can be for the early screening. We can do a few panel tests like CBC panel, metabolic panel, vitamin D, and what are the other albumin protein levels, right? Because patients always want an objective number. They are not going to believe in any talks. They just want it on report. Now, if you all go to see the research studies, Right frailty criteria is one of the criteria which has been fitting along in most of the research studies. What it says is that unexplained weight loss greater than 5% over the year, over 1 or 6 months to 1 year. Exhaustion, unexplained exhaustion, which do not have any organic cause, like there is no heart failure, no hypertension, no diabetes, still the person is exhausted. Okay, so it is just not out of his mind. He is actually exhausted. Weakness, poor hand grip strength. Hand grip strength is a very good outcome measure to tell anybody that he is in the weak category, weak strength. Slow walking speed, low physical activity. So if of this, if we are 3 plus, then we can classify that patient under frail, and if 1 to 2 points are positive, then we can classify them under pre-frail. There are other tools now. The PGs would like be interested in that. You can use it for your research purposes, right? You already discussed that. Clinical frailty scale is another tool. It has been very commonly used. CFS and Edmonton frailty. What is the medical management? Is that address all the chronic diseases that patient is undergoing, be it heart failure, any acute coronary syndrome, or any neurological disease. Okay, the frailty might overlapping the organic disease, or it might without be any organic disease. But always first and foremostly always address the organic disease. Okay, so that should be effectively managed. Polypharmacy I already discussed. Optimum nutrition. It is always, some things are beyond our scope of practice, so we can always cross-refer the patient for a nutritional guidance. Manage mood disorders and social factors, so we can do some group activities, some fun-based activities, including some cognitive-based rehabilitation to encounter and touch the patient in a holistic way, and just not to improve the physical function. That might enhance his mood. Vaccinations again important for all our pulmonary patients. So timely doses of the common infections that the patient might get, timely vaccinations has to be done. For prevention strategies, education is one thing we can always guide the patient to prevent the fall, be it using of assistive devices, acceptance of assistive devices. This was a scoping review done in 2025. Now pre-frailty is a very new topic. Okay, not many researches have been done up till now for pre-frailty. So whatever you find is going to be very new. So this is a scoping review. Physical exercise intervention characteristics and outcomes in frail and pre-frail older adults. It's a scoping review, and there were 18 studies in this review who met the eligibility criteria. Then what studies they selected? They were multi-components, like various exercises were included. Aerobic activity is at 70% of the max effort. So 70% of the max is the intensity of exercise for the aerobic training. Strength training at 20 to 80% of max, and approach proved effective for frail and pre-frail older adults. So what did they conclude is that exercise is an effective intervention for frailty. Still, we are very new to this. There is a lot of research to be done. It's a very new. There are many new terms coming out, like failure to thrive. The failure to thrive, we always use it for the pediatric patients. These are the new terms coming for our other vulnerable population, that is elderly group. So what did they find? These are the various domains, and there were multiple outcomes depending on each study of the 18 studies that. So they observed that there was decrease in fall in 70% of the studies, 70% of the 18 studies. Increase in walking speed was observed, increase in balance. So all of them involved multi-component training that was inclusive of aerobic resistance, balance, and flexibility training. Okay. There was increase in strength by 70%. increasing functional capacity. Now, patient is always interested in increasing in functional capacity and strength, right? And as we discussed that since pre-frailty is a reversible condition, one study also observed that pre-frailty was reversed. Okay. Increased dual task performance, memory and mood, and reduction in the fatigue levels. Price criteria linked with mortality, Edmonton scale it showed strong critical for 2-year mortality. Okay, so whenever you tell patient anything which has an objective outcome and objectively it has been proved into the research, they will be more likely to believe it. This was another study published in 2024. It is a systematic review with a meta-analysis. They took into account community-based exercises compared to the individual exercises. So they included only RCTs, 22 RCTs were there. Where there were 900 in the intervention group and 115 in the control group. So what did they find out was lower limb strength, lower limb function, reversal of pre-frailty increased, right? So there was increase in the strength and function of lower limb, which is majorly required for any function to be done, and there was reversal again of pre-frailty observed. They concluded that community-based exercises were superior to minimal intervention in improving health status and reversing of pre-frailty. Again, what is the intervention they give? It is based, so interventions are not going to be something, something out of universe. It is always going to be same. What is the WHO guidelines say? How many days a week do we have to exercise? 5 days. 5 days. And what is the intensity?
60 to 70.
Moderate intensity. Okay, and time?
45 minutes. 30 to 45 minutes.
For a week?
60 minutes.
Okay. So, you'll have to go back and see what does the WHO say. Okay, what is the, so guidelines are always going to be same or similar, be it any society. Okay, be it AHA, be it WHO, everything falls under the similar aspects. What we have to tell the patients, the patient is not going to listen if you tell AHA tells this and WHO tells this. What he wants is, will I be able to do this or not? Okay, so in that line you have to explain the patient that if this intensity you do, you will be able to do your work, or you will be able to do any leisure activity, even if he wants to, not for his occupation, but any leisure activity if he wants to do. Okay, so you can refer these articles where if you want any particular intervention, like what amount of strength training, what percentage, what is the intensity they targeted, and what was their outcome measure. If you want to show patient that okay, today you are able to lift 2 kg, maybe tomorrow you will be able to lift 5 kg. Right? So you can read there are almost 22 RCTs here. So 22 studies for you to explore, just not this one systematically. Fall prevention again is an important aspect because the quality of life really deteriorates even after one fall. So what do we take away is that pre-frailty is a critical intervention window period. We have a good golden period to prevent what we do not want. It's a low cost, high impact for resilience and independence. And we are not going to work alone. We have a full team. It is always going to be a holistic approach. And it is just not us, right? And we all can build resilience, no need for a $1 million biohacks. Okay, so we do not need any fancy experiments like Mr. Byron Johnson had done, right? It is just lifestyle-based interventions and prevent is the motto. Okay. Thank you. Any questions? Anyone?
We have seen the cognitive part and visual part. Now, how to incorporate the cardiorespiratory part in like aging?
first we need to know who is pre-free. Right? So as I said, we need to do lot and lot of screening. Be it our rural camps or even in the hospitals, you can screen the not the patient but the caregivers. Right? So you first have to do lot of screening. And once you get that data and you understand what is the prevalence of pre-frailty in your setup. Right? So then you have to discuss it, you have to make a plan, and then you have to make a plan for rehabilitation into that particular group. Now that can come out in a fun-based activities, as in morning Dr. Harira was talking, that functional, fun-based activities you all had done. Okay, so it has to come out in that, and you have to design your intervention, like you can do low intensity, depending on the group, 60 plus low intensity where the heart rate does not go much, but it is still 120-ish something. So you have to target it indirectly. Maybe low rhythm songs you can choose. So in that you can do some using the large muscle groups, where your upper limb, lower limb both. And before that you can start with some stretching in the warm-up phase. Right? So, but before that you need to identify who are your population and who is the vulnerable. Or you can do even before screening, assuming that even we don't want to go in the pre-frailty stage. So just once a week you gather some 20 people and you make them do some few aerobic exercises. Okay, but here the thing is, the patients or the people are not going to come to you. Okay, nobody comes. Even we have tried this a lot. We used to do, like in our cardio wards, we used to go and give this talk about health education. We started with a lot of postures in vernacular languages, but we did not get a good response. Then we understood that why it is happening. Then we listened to them that they are still not educated. They don't know what are the repercussions they are going to have, even after doing a study. They come with a restenosis. So that basically when we talk about any cardiovascular condition, education is the first thing. That what they should anticipate that they might get into. So you start with education, then you start with screening, and then you can make up a rehab protocol.
Anybody else has any question? Any clarification?
Same thing you can start for your pulmonary patients also. Another group, COPD, ILD, who are already into the free category. So before screening or before assessing, you all can straight away start with a rehab or group-based rehab or something like that. Okay, so it will be a quick thing for even the patient. They will get motivated because long-standing chronic conditions are always, I will not say depressive, but it is not very good to have a long-standing chronic lung condition. Okay, so it will enlighten the mood and enlighten what an exercise can do. And there have been observed lot of kinesiophobia. I think PGs might know. Yes. Right? So kinesiophobia is again one term that we have been encountering a lot these days. Fear of movement. Even if they walk on like 30, 60 meters, they get breathless. So something, you know what, if they do it in front of us, they might get little confident in doing activities when they go back.